Hello, dear students and friends. We all know that placenta accreta spectrum is one of the most feared complications in modern obstetrics. The real challenge is not only the diagnosis, but the management aspect. Deciding the right plan for the right patient at the right time is very crucial. In this session, I would address the practical management dilemmas and evidence based strategies and how to improve outcome. Placenta accreta spectrum, recent advances, part 2, which is mainly on management options. You would agree that it is a management dilemma. In the 24 hours of the day, anytime, it may come as a surprise diagnosis if not well planned. And it does become a acute obstetric emergency and may require urgent referral to a PAS referral center. Well, in the previous video lecture, I had discussed the various diagnostic methods and then the antenatal care. Now coming to the treatment. Before that, I had discussed the preoperative and operative guidelines which had to be followed. The treatment essentially is surgical, and rarely we may see cases in which the patient came in full dilatation, delivered, and then retrospectively we find out that the placenta is adherent. So those cases are very rare. And essentially, the plan of management for these cases is a cesarean section and various surgical approaches. High quality comparative data are lacking, and the optimal surgical approach depends on multiple factors. Dozens of approaches have been described in literature, but none is clearly superior. These strategies have been condensed into 4 groups. First, a cesarean hysterectomy after delivery of newborn with the placenta left in situ. Then second approach is conservative or expectant in situ management of the placenta. Third, planned delayed hysterectomy weeks after in situ management. And fourth, partial myometrial resection and uterine reconstruction. If the diagnosis is made before viability, a gravid hysterectomy with placenta and fetus in situ is a rare condition but reasonable option for patients with PAS. Now, first, cesarean hysterectomy. That is removal of the uterus with the placenta left in situ after delivery of newborn. This is the most appropriate approach for placenta accreta spectrum with active hemorrhage and hemodynamic instability. The patient is bleeding a lot and nothing else can be done. It is a default backup plan or salvage approach when the other treatment strategies fail. In the absence of very severe disease, by severe disease we mean FIGO 3B, 3C, or even 3E pass grade, and in hands of experienced surgical team, some experts believe that this approach reduces the risk of worst outcomes compared to alternative approaches. This is a cesarean hysterectomy performed in a setting, and it is technically complex and hazardous. Should be performed by a surgical team with experience. Now, it has been seen that patients with PAS are particularly vulnerable to acute hemorrhage, profuse bleeding. The reasons are the architecture designed to generate high flow resistance for the growing fetus creates a precarious surgical field, with rapid loss ensuing even from minor disruption of placental tissue from the uterine tissue or uterine vasculature. The third trimester gravid uterus is 30 to 40-fold larger in size and hence more bleeding. There is a 10-fold increase in blood flow, as high as 17% of the cardiac output, or nearly 700 ml per minute. So these are the reasons why the bleeding is torrential. Surgeons must be comfortable operating in the retroperitoneum near the pelvic side wall because there's an altered anatomy, a widened and distorted lower uterine segment. There are aberrant locations of uterine vessels, ureters, and even a distorted bladder. Abdominopelvic adhesive disease could be there and it could be related to any prior surgeries. Here, a vertical midline incision is chosen to allow adequate exposure. Delivery should be through an incision or a hysterectomy well away from the placental site to avoid placental disruption. Ideally, first mapping of the placental location with sterile intraoperative ultrasonogram directly on the uterine surface and performing uterine incision away from placental site should be done. During hysterectomy, a stepwise devascularization of the uterus beginning at the uterovarian pedicles allows mobility of the postgravid uterus and reduction of collateral blood supply and reserves the most difficult dissection for the last. The difficult areas which have highest vascularity have to be dissected last, including bladder and lateral isolation of vascular pedicles. Now, the use of electrodissection and vessel sealing devices. Each of the currently marketed vessel sealing devices, a maximum vessel diameter 7 mm can be used, which may be exceeded by the size of vascular pedicles in past. So a combination of a sealing device and traditional suture ligation techniques are ideal. Placement of a special retractor, Risky's retractor in the vagina, may assist in identification of the top of vagina as the determination of transition from cervix to vagina in these cases becomes quite challenging. The second approach is conservative in situ management, also known as expectant management, a potential way of preserving the uterus for future pregnancy and to reduce surgical morbidity. In this technique, the newborn is delivered by cesarean away from the placenta. The cord is trimmed short, tied off near the cord insertion. The non-adherent portions of placenta may be trimmed away, or the entire placenta may be left in situ undisturbed. Then the uterine incision is closed. If there are no immediate bleeding complications, intra-op. During the initial period of observation, the abdomen is closed. So you wait for some time and see whether there's active bleeding. If there's no bleeding, abdomen can be closed. The patient can be kept on expectant management till there is complete resorption of placenta or there is an indication to abandon, like uterine sepsis and excessive secondary hemorrhage. The advantages and concerns of this method, it may reduce the risk of major surgical morbidity and bleeding, although the absolute number of cases described in literature remains quite low. The recent Accreta study was a non-randomized observational study from France. They have found reductions up to 70% for transfusion, blood loss, and operative injury to the urinary tract or colon compared to immediate hysterectomy. So it was successful in avoiding hysterectomy in 78 to 94% cases. However, there are several concerns: endometritis and repeat operation, which could be emergent or non-emergent, and prolonged follow-up. Now, the third option is a planned delayed hysterectomy. This is an approach to minimize the risks associated with immediate hysterectomy versus conservative management. This allows definite treatment while potentially mitigating risks. Before the delivery of the newborn by cesarean, a systematic evaluation for remodeled uterus, bladder, parametria, adhesive disease, and other pelvic organ involvement should be done by the surgical team. Then they need to proceed to whatever surgical team agrees, because at this situation, if a hysterectomy is a feasible option, a cesarean hysterectomy can be performed. In a delayed hysterectomy, the newborn is delivered and another systematic evaluation is performed to ensure the integrity of hysterotomy and absence of clinically significant vaginal bleeding. Again, at this stage, if there is vaginal bleeding, a hysterectomy again can be performed. The role of adjunctive procedures in order to minimize blood loss, like femoral access, ureteral catheter placement, resuscitative endovascular balloon occlusion of the aorta, pelvic artery embolization, and postoperative antibiotics are still under research. So this is how initially a bigger uterus with placenta in situ becomes, with conservative approach, becomes smaller, and it is then that vascularization decreases, and then a delayed hysterectomy can be performed at a later date. Again, the advantages and concerns. It remains an investigational approach. Data from several studies show lower estimated blood loss, 750 to 850 ml versus 2000 to 3000, lower transfusion volumes, fewer transfusions, more than 4 units compared to an immediate hysterectomy. Because this strategy requires 2 planned surgeries and possibly a multiple hospitalizations, it is associated with longer total surgical times and longer postoperative lengths of stay. Rates of surgical and postoperative complications are similar to rates in those undergoing immediate hysterectomy. The most common complication reported across studies were infection of urinary tract and surgical site. Now, the fourth option is partial myometrial resection and uterine reconstruction. This means en bloc resection of placenta and attached myometrium in well-selected cases, followed by repair and reconstruction of the remaining uterus and cervix. This strategy is typically performed during the same surgery as cesarean delivery. Important to the success of this approach is the experience in determining at the time of surgery whether to attempt resection or proceed directly to hysterectomy on the basis of individual patient characteristics. These factors include sufficiently viable myometrial tissue surrounding the affected area, degree of hypervascularity, location and severity of pelvic adhesive disease. Knowing when to use this approach is a nuanced skill that comes only with experience. So this can be done in experienced hands only. Some investigators couple resection and repair with pelvic devascularization procedures like compression suturing, incorporating cervix into the closure, or tourniquet placement to reduce blood loss during uterine repair and reconstruction. Society for Maternal-Fetal Medicine, ACOG, state that this approach should be rare and considered individually. Future pregnancies and considerable risk outcomes include recurrent past and subsequent pregnancy, uterine rupture, and preterm birth. The few case series addressing these questions are not definitive to rule out any significant harm. So here, intraoperative appearance of placenta accreta spectrum, increased vasculature on the anterior uterine wall, evidence of which shows evidence of placenta percreta, then giving a high uterine incision, delivering the baby, and umbilical cord ligation close, then bilateral artery ligation, excision of a portion of placenta, and reconstruction. Specific uterine sutures need to be placed at the time of reconstruction, 2-layer horizontal 8-shaped stitches at the angle, also special assembly suture for the angle may be required. Now, another procedure which was commonly being practiced and which has been mentioned a lot in literature is the triple P procedure. Perioperative placental localization, pelvic devascularization, and placental non-separation with myometrial excision. It is the same as the previous procedure. The 3 key steps involved in this are perioperative placental localization and fetal delivery. Again, with the help of ultrasound performed immediately before the operation, the exact location of the placenta's upper border is identified. Then the surgeon makes an incision transverse uterine above the border into the uninvaded area to deliver the fetus. Pelvic devascularization can be performed after the baby is delivered. The original technique involved inflation of pre-positioned occlusive balloon catheters into the anterior division of internal iliac by an interventional radiologist. Placenta non-separation and myometrial excision and uterine repair was then performed. Placenta attached to the myometrium was removed and masked depending on individual characteristics. So these are pictures showing this technique. Advantages: reduced blood loss, lesser complication rate, especially reduced incidence of urinary tract injuries, uterine preservation, and shorter recovery time. However, limitations and considerations: the procedure requires advanced expertise and a dedicated multidisciplinary team, including obstetrician, anesthesiologist, and interventional radiologist. Can only be performed at a tertiary care center. With all these facilities, modifications to this technique have been developed in resource-limited settings like using temporary internal iliac clamping or uterine tourniquet instead of endovascular balloons. Overall, it offers a safe and effective conservative approach to hysterectomy for managing suitable cases of the placenta accreta spectrum. Now, a new technique to preserve the uterus and placenta accreta spectrum using the Zhukovsky's double balloon tamponade at cesarean section. This has been mentioned in the American Journal of Obs and Gynae 2024. The vaginal balloon is placed before a cesarean. At the time of cesarean, this balloon is inflated. After the delivery of the baby, the intrauterine balloon is placed and inflated. And this is how, by compression, if you are considering the conservative approach, or even if you are doing a cesarean hysterectomy, blood loss can be minimized. Various endovascular approaches again to reduce blood loss, giving a hysterotomy incision at the fundus, various multi-vessel targeted embolization, abdominal aorta, internal iliac, uterine, or even common iliac. This mentions a step-by-step algorithm with the use of a Zhukovsky's catheter. So initially, step 1, bladder catheterization before surgery and insertion of the catheter, which is in collapsed situation. Low midline laparotomy is then done. Evaluation of the lower uterine segment. A high transverse uterine incision 4 to 5 centimeters over the predicted placental edge, fetal extraction, cord clamping, and separation. Expansion of the vaginal catheter with 180 ml saline. Exteriorization of the uterus, ligation of descending branches of uterine arteries from the posterior uterine side. Then decide whether it is grade 1, 2, or 3. In pass 1 and 2, if the placental invasion is less than 1/3 of the myometrial thickness, excision of the affected portion of uterus, simultaneous ligation of the hemorrhaging vessels, H-shaped suture at placental site, separation of utrovesical fold, and external supraplacental assembly compression suture, and placement of uterine catheter. Or if the invasion is more than 2/3 of the myometrium thickness with an area less than 5 centimeters, removal of affected portion of the uterus together with the placenta, metroplasty, supraplacental assembly compression suture, and placement of uterine catheter. So, partial resection followed by placement of uterine catheter. In pass 3A and B, separation of the affected portion of placenta, avoidance of bladder, ligation of vessel anastomosis on the anterior and posterior anterior-uterine posterior bladder wall, addition of ligation of descending branch of uterine artery, external supraplacental assembly compression suture, removal of affected portion of uterus together with placenta, placement of assembly suture at the corners of the uterus, and placement of uterine catheter, closure of uterine incision with individual H-shaped sutures. So in these two techniques, even though you're removing a portion of placenta and bladder, compression by the uterine part of this catheter helps in achieving or reducing blood loss and achieving hemostasis. If it is a PAS 3C, means invasion of the cervix, infiltration of parametrium, or there's intraoperative uncontrolled bleeding, hysterectomy with uterine and vaginal catheters in place. So even if you're deciding a hysterectomy, this Zhukovsky's catheter can be used. Another interesting article, a novel transvaginal ultrasound scoring system quantifying the placental Accreta spectrum severity and its associated blood loss. So it is a predictive model which helps in management as well. So here scores depending on initial 3 scores are calculated. First, the uterine wall score, hypotranslucent interface at the lower uterine segment with placental attachment more than 3 mm. Depending on the diameter, 0, 1, 2, 3 scores are given. Then second score includes arterial vascularity score, analyzing pulsatile low resistant flow on color Doppler at interface. Again, depending on the visible number of visible arteries, a score is given. And then the cervical score, proximity of pathology to the cervix. So depending on the area of location, again scoring is done. Then a cumulative overall pass score is given, and it is categorized depending on the score, a score of 0, which means routine obstetrical care, cesarean delivery with possible removal of placenta is possible. In category 1, a score of 1 to 3, intraoperative evaluation with consideration for cesarean delivery with possible removal of placenta and cesarean hysterectomy. In a category 2, a score of 4 to 6, cesarean hysterectomy or alternatively conservative management is possible. In category 3, when you get a score between 7 and 9, cesarean hysterectomy with potential additional vascular occlusive measures to reduce blood loss, or conservative management if suitable and no bleeding, specifically if there are cervical lacunae, if you have a score of 9 in the cervix. So this was the novel PAS scoring system in order to assess the severity of bleeding. The take-home message: PAS is a condition that places patients at high risk of hemorrhage, surgical complications, and even death. Care of patients with PAS is best accomplished at centers with ample experience and resources to manage the breadth of both physical and psychosocial needs. In prenatally diagnosed cases, caesarean hysterectomy is the most common and definitive approach. Considering conservative or alternative management approaches depends a lot on expertise and resource of the institution, the severity of PAS, and the patient's preferences. Thank you. If you found this video lecture interesting, please subscribe to my channel. There are many more. Thank you.